I'm KeithO Hudson. I've been an insulin-dependent diabetic for over 20 years. At my highest weight, I was using over 400 units of insulin a day. I've been able to lose 100 pounds and get off insulin altogether. I'd love to share my story with you if you are trying to do the same thing. I absolutely know that it is possible to take control of your blood sugar and obtain tight blood sugar control because I have done it. If you are an insulin-dependent diabetic that wants to improve your blood sugar control, there are some important terms for you to learn. Insulin-carb ratio means the amount of insulin needed to cover a certain number of carbohydrates. For example, an insulin-carb ratio of 1 to 10 means that if you eat 10 grams of carbs, you need 1 unit of insulin to cover those carbs and return your blood sugar to what it was before you started eating. Insulin sensitivity factor means the amount your blood sugar will go down from 1 unit of insulin. This calculation is important to correct high blood sugar levels. For instance, if you know from experience that 1 unit of insulin lowers your blood sugar by 10 points, and your blood sugar is 40 points above your target, and you have no insulin on board, you need 4 units of insulin to return your blood sugar to your target reading. Insulin on board means the amount of insulin still active in your body from previous doses, also called boluses, of insulin. Knowing what your insulin on board is helps prevent insulin stacking, and therefore helps prevent going low or suffering hypoglycemia. Hypoglycemia is a very dangerous condition if you don't pay attention to it and know how to treat it. It can lead to coma and even death. However, when you're well informed and you know how to check your blood sugar levels and how to take care of them, then this is something that then hypoglycemia is very preventable. In order to know what your insulin-carb ratio is and your insulin sensitivity factor, you need to learn how to calculate those. The book, Think Like a Pancreas, at page 184, explains 2 different methods for calculating your insulin-carb ratio. The first is the 500 rule. The 500 rule is based on the assumption that the average person consumes, through meals and snacks, and produces, from the liver, approximately 500 grams of carbohydrate daily. Dividing 500 by the average number of units of insulin you take daily, you should give you a reasonable approximation of your insulin-carb ratio. That formula is 500 divided by TDD, total daily dose. For example, if you take a total of 25 units of insulin in a typical day, each unit of insulin should cover approximately 20 grams of carbohydrate. If you take 60 units daily, your estimated insulin to carb ratio would be 1 to 8. Now, there is an unspoken assumption in that section of the book that I think has to be understood. And if you truly want to lose weight and return your blood sugars to normal without the use of insulin, needs to be rejected, because the assumption is that you will be ingesting on an average daily basis 500 grams of carbs. Yes, that section refers to the glucose stored in your liver that's released into your bloodstream, but where does that come from? it can only come from carbohydrates that you have ingested in the past. And as we'll learn in later lessons, when you learn to reduce your carbohydrate intake, your daily carbohydrate intake, to a very minimal amount, all of a sudden your blood sugar control becomes much, much easier. One thing to keep in mind is that your insulin-carb ratio might change throughout the day. Careful record keeping will help you identify changes in your insulin-carb ratio throughout the day. Another important element of understanding how much insulin you need is to understand the different types of insulin and what their action profile is for you. For instance, I used to take Lantus and later Levemir as a 24-hour insulin to cover my basal insulin needs. The action profile of Levemir is that it begins working within 1 to 2 hours after administered and continues to work on a relatively steady level for 18 to 24 hours, depending on the dose and the individual patient factors. This also begins to work within 1 to 2 hours and provides a steady release of insulin and lasts about 24 hours. Both of these insulins are ideal for covering your basic or basal insulin need. Humalog, by contrast, is a fast-acting insulin. It starts to work in about 15 minutes after it is injected. The peak effect occurs between 1 and 2 hours after injection, and then it tails off, lasting for a total of 3 to 5 hours. By measuring my blood sugar at frequent intervals after eating and taking Humalog, I was able to determine that for me, 90 minutes after I inject Humalog, about 50% of that Humalog is still active in my body. So I did, through careful record keeping and experimentation, I learned what my insulin on board was at 30 minutes, 60 minutes, 90 minutes, 120 minutes, and 150 minutes after taking Humalog. This allowed me to have much better blood sugar control than simply trying to do one calculation of how much insulin I needed for the food I was about to eat. I will confess that I hate having to count carbs and do complex calculations before I eat. And so what I found works for me is to minimize the number of carbs I eat and take a conservative bolus of Humalog at the time I eat. Then check my blood sugar 90 minutes later when I know that 50% of the bolus I took right after the meal has left my system. Knowing my sensitivity factor, I could then calculate what additional bolus I needed to return my blood sugar to my target level. Based on my research and my experience, my target level for my blood sugar was 83. I know there are doctors who are nervous about having their diabetic patients try to achieve a target blood sugar level that low. I do not advise it if you are not willing to pay close attention to your blood sugar, learn everything you can about how to manage your blood sugar, and be prepared to have lengthy discussions with your doctor if needed to educate them about diabetes. If you spend 10 hours studying how to control your diabetes, you will probably have about the same amount of education your doctor received on managing diabetes during medical school. If you've studied 100 hours or 200 hours how to manage your blood sugar, you will likely know more about how to properly manage your blood sugar as a diabetic than any doctor you will ever encounter. If you find one that knows more than you and will partner with you in your care, hang on to them because that's gold. If you find one who thinks they know a lot about diabetes, who is not themselves an insulin-dependent diabetic, but who will not engage in a two-way discussion with you, but behaves as though they know everything, run away and find another doctor. Or be content to have higher average blood sugars than necessary and live with more symptoms from your diabetes than you would have if you took control of it yourself. Years ago, I read a book called The Rosedale Diet, which talked about managing blood sugar. I couldn't find my copy of that book, but in that book he said, if you follow the recommendations of the American Diabetic Association, it will kill you. But they're designed to kill you slowly instead of quickly. More on that in another discussion later on. Thanks for listening. I hope you'll like and subscribe. Tell anyone else you know that's an insulin-dependent diabetic about this. Have a great day.